Guys, this is Dr. Mobeen from Drbeen. Today we'll talk about the case fatality rate or death rate caused by COVID-19 disease, which in turn is caused by the coronavirus SARS-CoV-2. So let's start our discussion. I have no disclosures. The objective for our discussion today is number one, to understand what is the case fatality rate. Then the data that I will discuss with you, what are the limitations of that data? Then how rapidly is the virus spreading, which would tell us that this data that we see, how applicable and how fast it is applicable. Then the type of cases for COVID-19 disease itself. Then mortality rate versus the mortality risk. What is the difference between them? Finally, what are the stages of COVID-19 disease itself? Because various stages have various mortality rates. And then this is the most important thing that I want to convey today, and that is the mortality rate is different at different age groups. This is what is really important for all of us to understand. It is not that out of every 100 people there are 3 who are dying. That is correct, that is the average, or 3.5. But it is also important to understand that various age groups have different mortality rates. And due to that, once we understand that, that is when we will try to make sure that those who are vulnerable in our society, those who are more at risk, then how do we understand how to protect them? And those who are less at risk, or those who are not, whose death rate is really low, the age group, how should they behave around those whose death rate is high? That is the primary objective for this discussion today. So we'll do the statistics by age, gender, and comorbidities. And then finally, we'll compare the case fatality rate or death rate of COVID-19 and flu. So let's start our discussion. So for the background, first of all, what is a case type? So for the COVID-19 disease, so this disease is the disease caused by SARS-CoV-2 or novel coronavirus or Wuhan coronavirus, the coronavirus species that is a new species that infected us in December 2019. And since then it has become a pandemic. It has caused lots of deaths. It has spread to 135 countries, at least till today. Today is 14th March 2020. So what are the cases? So the cases are for this disease are suspected case, according to WHO, that you suspect that this person may have it. Then probable case, where you try to test the suspected person and see if there is still a probability or not, and then a confirmed case. So look, definition of a close contact is first to understand, because many of these cases, the disease itself is coming from people to people nowadays. It was from animal to people in the beginning, but now there is a community spread now. There is a people to people spread. So due to that, we have to understand what is a close contact. So the definition of close contact on CDC, US government, is that when someone has been in 2 meters distance of a person who has COVID-19, and this person, the healthy person, has stayed in the presence of a patient of the COVID-19 for a prolonged period of time. For example, they are healthcare workers taking care of the patients, or they are family members of the patients, or visitors of the patient, or they've been sitting next to them in the clinical settings for a prolonged period of time. Or the other case of a close contact is when someone who has come into contact with the secretions or excretion of a COVID-19 patient. For example, saliva or tears or nasal secretion or stools of a patient. So with this being the definition of close contact, now let's look at the case definitions. So the suspected case, according to WHO, look, the basic idea is very simple. The disease, COVID-19, the primary symptom is fever with dry cough. That is a primary and important thing. Shortness of breath can be next. So a suspected case is when you have a patient who has a respiratory illness. For example, they have fever and at least some signs and symptoms of respiratory issues. For example, they have cough, sneeze, shortness of breath. Or no other etiology, no other cause can explain why are they having this clinical presentation. And a history of travel or residence in an area where there is this disease. Or having been there either in close contact or in those territories for at least 14 days before the symptoms start. That means if I started the symptoms today, if I started having fever today and I started having, let's say, cough today, then within 14 days, did I go to a place where COVID-19 has been spreading and so on. So that is one way of suspecting a case of COVID-19. Another way is that we have a patient of respiratory illness, as I discussed before, fever and shortness of breath or cough, and then they have been near a confirmed case. And that may be a family member, that may be a healthcare worker. So the closed contact, they have been in close contact, and we have defined the close contact before. So they have been in close contact with someone for 14 days before their own symptoms started. So that is another type where we should suspect COVID-19. And then a patient with severe acute respiratory illness, fever, shortness of breath, respiratory, maybe cough, sneezing, and they require hospitalization. And so the situation is so bad that they have to be hospitalized, and there is no other reason to explain why all of a sudden they have developed this. So all of these cases make a suspected case of coronavirus or COVID-19, that is SARS-CoV-2 virus. So then let's see what is a probable case. If you take a suspected case and then you test them in the labs according to WHO's lab testing criteria, and the test comes back inconclusive, then you say, well, this is a probable case. And finally, a confirmed case is, of course, the situation where you take a suspected case, you do the lab testing on them, and the result comes back and they confirm that this is a case of COVID-19, then that is a COVID-19. So that means you take a suspected case, you do the labs on them. If the labs are inconclusive, then they become probable case. And if the labs are conclusive, then they become a confirmed case. Now remember this, the data that we would discuss today, the death rates that we would discuss today are going to be the confirmed cases death rate. I want to also mention one more thing. There are so many cases of this disease that are not counted because either the patient is asymptomatic or the patient has such mild symptoms that they never even went to a doctor to say, I'm sick. So they're not even counted. And it is suspected that those cases that are not being counted are anywhere 10 times to 20 times more than the ones that are counted. So keep that in mind when you look at the data. Why is that important? That is important because if I say that out of 100 people, 2 died, then it is 2% death rate. But if the actual count was 1,000, then it is not a 2% death rate, it is 0.2% death rate. So this is why it is important to keep in mind that we are in the middle of the pandemic. We are not able to exactly count the people who are sick and exactly count people who have died, because there may be people who are infected today and might die later, which are not counted. So keep that in mind. We're talking about the confirmed cases only. So how accurate is the data? This is the same discussion I just had. The data is not very accurate. The reason for that is that there are a majority of the patients, younger patients, children, younger patients, which is 10 years, 20 years, 30 years, up to 40 years, they can just be asymptomatic. They could have the virus replicate in them and even shed that virus to others. They are infectious, but they are asymptomatic. They're not counted. Then there are people who develop very mild symptoms. Once again, they may not show up at a doctor. They may not suspect they have corona. They just thought they have some mild cold, and they are not counted either. So again, that skews our data. Then there are countries who do not have the capability or readiness to test everyone who may have the infection. So first they have to go and figure out who to track. Where are the people who are infected? Maybe they do not know how to track them. Maybe they do not know how to find them. And secondly, even if they have found them, maybe they do not have the kits to test them. So there is a lack of resources or lack of readiness and lack of preparation, lack of contact with the community, lack of awareness in the community to come to the doctors to be counted is all part of the problem that data is not accurate. Then on top of this all, we are still in the middle of this pandemic. It is not over. So we do not know the total confirmed cases and we do not know the total deaths because the pandemic is not over yet. So as a result of this, please realize this. I have highlighted that here in red. The total confirmed cases are actually not equal to the total cases. It is possible that in a community there are 1,000 cases, but the only confirmed cases are 100 or 50 because they are the one who turned up. So this is the situation. Now, how rapidly the virus is spreading? Why this is important is that if the virus is spreading very fast, then the death rate will be high as well, or the number of deaths, not the death rate. The death rate would be what it is. The number of deaths will be very fast as well. The burden on healthcare system, the peak, if the virus is spreading fast, the peak of the people who are ill will be a bigger peak, and the burden on the healthcare system will be high as well to provide the services. So this is why the way we are trying to work with this pandemic is to try to flatten the peak and delay the outcome of the infection, or delay the catching of the infection by as many people as possible, so that they do not all turn up in hospitals at the same time. Then the hospitals will be overwhelmed, just like in Italy right now, and there would be an issue. So how rapidly is the virus spreading? Check this out. Worldwide, the number of confirmed cases are doubling within 27 days. In China, they doubled in 33 days. And in some countries, they're doubling even faster. India, 6 days. Pakistan, 5 days. Spain and France, 3 days. So please realize that as the numbers are doubling fast, people who may actually think that, hey, we should not be much worried about coronavirus or this virus, they would very soon see that the countries, the spread would increase because the number of cases are growing exponentially. And on top of this, WHO has now declared Europe as an epicenter of the disease. It was China before. China has very successfully and brilliantly contained at least their own situation, and now Europe probably was less ready or probably was not very careful. Whatever is the situation, without any criticism, at this time, Europe is the epicenter. My suspicion is the South Asia, India, Pakistan, Bangladesh, those kind of countries, or Middle East can become the next epicenter if they do not learn a lesson from the remaining world right away and start taking care of the issues quickly. And now to see the remaining list of all the countries, there are 135 countries that have infections on this date, again 14th March. You can see that list on this reference that I have given here. Now, what is a case fatality rate? Remember, it is a rate, so it's a percentage of death. So first of all, if somebody asks me that, hey, can you tell me what is the risk of mortality for someone? We cannot predict that today because we are in the middle of the pandemic. There may be so many people who are infected and who might die later on. They are not counted. So the exact numbers, exact percentages are still not countable. That would only happen once the pandemic is over and the final numbers are in. So till that time, the risk projection is not exactly possible. However, we know that there are the number of confirmed cases present. We know them, and we know the confirmed deaths. And we can at least say from the confirmed cases so far, what is the death rate, and that will be the case fatality rate. So today, confirmed cases are 142,649. Deaths total, confirmed deaths from these cases, from this disease, 5,393. So the case fatality rate is 3.78. It has started from somewhere near 2 and it has now climbed to 3.78. This is what had happened with SARS-CoV in 2002 and 2004 as well. That is when during the epidemic, SARS-CoV case fatality rate were presented as 3 to 5%. But once the epidemic finished and the final numbers were counted, then the CFR was 10%. So who knows where this CFR would go, but this is while in the middle of pandemic, this is the number that we have, 3.78%. So out of every 100 people, about 3 or about 4 people will die. So that is the confirmed death rate. Now, how is the CFR calculated? We take the total number of deaths confirmed, divide that by total confirmed cases and multiply that with 100. So that's a percentage of the people out of every, meaning out of every 100 people, how many people have died. So that is the calculation. Now, I have used this data from this brilliant site, I'm sure that you are aware of it as well, Our World in Data. And they have a great page on coronavirus and all kinds of stats over there. So here, what I wanted to make sure is that we understand the stages of this disease. Just like we wanted to understand the types of cases, suspect and probable and confirmed, similarly, this disease, COVID-19, has its stages as well. So it is very important for you to understand that various stages have various mortality rates. So mild stage is when it's about 81% of the people would only have a mild stage. And in that they would have fever, maybe have short cough, and then they would, within 2 weeks, they would recover. Then severe case is about 14% of the patients in which there will be shortness of breath, there will be some respiratory problem, for example, the tachypnea would occur, that is the frequency of respiration would increase greater than 30. The oxygenation level would drop below 93 because there is an issue, there is interstitial pneumonia going on, or there is a problem with the oxygenation or the gas exchange because the virus has affected the lungs. And similarly, PaO2 and FiO2 ratio is lesser than 300. The lung infiltrate, that is the inflammation in the lungs, is greater than 50% within the 24 to 48 hours. So that is a severe case. 14% of the patients are in that category. And finally, critical cases are those who have developed septic shock and organ failure. They are really in trouble. So this is important for us to understand the stages: mild, severe, critical. Now, every stage has its own duration for the symptoms to stay and then the stage to resolve. According to WHO, the median time for the recovery from a mild disease is 2 weeks. And median would mean that 50% of the population who has mild symptoms will recover within 2 weeks. For severe and critical cases, 3 to 6 weeks. And for those cases who have died, those patients who passed away, about 2 to 8 weeks. So you can imagine from here, you can kind of think about it that as the number of weeks continue to increase and the patient is not recovering, the chances for them to have a bad prognosis continue to increase as well. Now, COVID-19 CFR varies. It is the case fatality rate is varying by country. I think it varies because of the containment and management processes various countries are undertaking. Even when WHO has given a particular specific agenda and a prescription for how to contain this, it is not necessary that every country is able to do that. For example, UK is not doing it. They are not complying with the way WHO has asked, and many other countries. So I'm not criticizing UK again, I'm just giving you an example that it is not necessary that every country is doing what is asked. The case fatality rate changes or is variant because of the location, because of the contamination tracking, then because of population type. The case fatality rate is lower in younger population. So if we have a territory or an area where the population is predominantly, let's say, young, they would have a lower CFR. compare that to some area where their older people are more, then the CFR will be higher. And then finally, please remember, as I said before, CFR will change when the pandemic is over and the final numbers are in. That is what had happened with SARS-CoV as well. Now, COVID-19 CFR until March 9th. So today is March 14th. So this data is up till March 9th. On March 9th, global CFR was 3.48. China's CFR was 3.86 and the rest of the world luckily is 2.39. So China had the highest case fatality rate because they had to handle this without having any example or preparation. And then the remaining countries have a chance to prepare and learn from others. So due to that, the rest of the world is 2.39 and the global average is 3.48, including China and the rest of the countries. Now here is a brilliant graph here that I wanted to make sure that we all understand. This is something for which I did this whole lecture. So this is what is important, that the CFR or case fatality rate is not the same for all age groups. So look over here, children 0 to 9 years, 0% fatality. Children seem to not even catch the disease, or even if they're catching it, they just seem to be the ones who are spreading it to others, maybe parents and the friends, but they are not getting too many symptoms. And this is a danger. Those age groups that are becoming infectious and then they are spreading it and they are not symptomatic, they are just happily being around us. And they do not know that they have a disease. We do not know that they are infectious, and they just simply are becoming the big machines to spread the virus out. So 10 years of age, 0% case fatality. 10 to 19 years, 0.2% case fatality. 20 to 29, 30 to 39, all of these, so up to 40 years of age from 10 years of age is 0.2%. 40 to 50 or 49, 0.4%. So see, younger ages have lower death rate. So we cannot just say that out of every 100 people, 3 would die. If there are 100 children who got this disease, none of them is going to die, which is a good news. And so case fatality rate, if there are 40-year-old folks, I think that there would be hundreds of them out of which one would die. But as you cross 50 years boundary, so 50 to 59, 1.3% of the patients are dying. 60 to 69, so up to 70 years, 3.6%. See how it is increasing? 3.6%. Then 70 to 79, 8% out of every 100, 8 people are dying in the age range of 70 to 79. And then 80 plus, 14.8% are dying. And why did I want to bring this to our attention here? I keep hearing from our colleagues, from our friends that, hey, this is 3% case fatality rate, everybody who becomes sick. So yes, that is the average. So every out of every 100 people, 3 are dying. But remember, the younger ages do not have a high case fatality rate. And it is the responsibility of the younger ages that they do not take that as a visa to now go around and just do whatever they want, and in that process shed the virus on everyone else. You are a young person, you come back from your college and you give that disease to your parents, that would be a problem. Similarly, children going to school over there, if they're contracting and they're receiving that virus from someone, maybe from another adult or another child, and then they go to their homes and give it to their parents and their parents' parents, and they can be dangerous outcomes. So please remember that we all have to be careful, including the youngsters. But the youngsters' care is not that they themselves are at a higher risk. They are not at a higher risk, but their contacts could be at a higher risk. So that is important. Then this is also really important, and that is the patients with comorbidities. That is, they have extra other diseases. They are at a higher risk as well, and this is regardless of the age. So there can be somebody who's diabetic and who's type 1 diabetic and who's young. They are at a higher risk. There can be somebody who's immunocompromised, and it's not necessary what their age is. If they're immunocompromised, if their immune system is not working correctly, they are at a higher risk. So the higher risk patient because of other diseases they have, out of them cardiovascular diseases, for example, strokes, coronary artery disease, myocardial infarction, ischemic patients, hypertensive patients, and so on, their case fatality rate is 10.5%. Diabetes, 7.3%. Chronic respiratory diseases, people who have other respiratory issues and chronic issues, 6%. Hypertension, 6%. Cancers, 5.6%. And no health conditions, 0.9%. So keep this in mind. And this is what explains why the higher ages have more case fatality rates, because they also have other comorbidities. People who are above 60, 70, 80, they may have diabetes, they may have cancer, they may have cardiovascular issues. So it is the comorbidities that are present which make them more vulnerable, not just the age. So if these comorbidities are present at another age group, maybe a younger age group, then that age group or that person is also at risk. And then finally, I wanted to share this, the CFR of COVID-19, fatality rate of COVID-19 versus flu fatality rate. So the first, some disclaimers here. The data that you're seeing here is a comparison of fatality rate of COVID-19 from China versus the flu fatality rates from the US. So these are two different countries. Their environments are different, their processes are different, the diseases are different. Then we know that for COVID-19, the fatality rate calculation is based on the actual confirmed cases and confirmed deaths from those cases. But in case of flu, we actually do not have that kind of data. We do not have confirmed cases every year, and we do not have the deaths from those confirmed cases. So we are going to be calculating the patients who visited the doctors because of flu, or patients who had symptoms of flu, and it may be other reasons, not just the influenza virus, but they have cold-like symptoms. So this data is not exactly 100% accurate. It is not apple-to-apple comparison. Still, it is interesting to see. So let's look at the data here. Let's start from the left side. On the left side is a seasonal flu from the US data. On the right side is the COVID-19 data. Look at this, all ages. Symptomatic patients, 0.1%. And if the patients, we just count those who visited the doctor because of flu-like symptoms, then 0.2%, 0.2%. Compare that to COVID-19, 2.3%, and as you know nowadays, 3.48%. Then if you look at various age brackets, 0 to 17 years of age for the seasonal flu, 0.004%, almost negligible. On the other hand, in case of COVID-19, 0.1% for this age group. Then if we take 18 year to 50 years or 20 to 50 years for COVID-19, 0.02% for flu and 0.3%, 0.3. So once again, about 6 to 10 times more fatalities in the COVID-19 case. Then 50 year to 64 years, if you see that age bracket, 0.06% for the flu, while the 1.3% for COVID. 9 to 21 times a higher rate of the fatalities with the COVID-19. And if then you look at 65 plus or 60 plus, 0.8% of the flu patient who are 65 plus would die, 0.8%, so 0.8 out of 100, and here 6%. So once again, almost 4 to 7 times more deaths for the same number of people who became sick. So that is the important thing. Yes, this is correct that flu has a larger scale, but the rate of people who are dying is higher in COVID-19. Thank you very much.